Well, good morning, everybody. It's 7:30, so we'll go ahead and get started. Thanks for tuning in for the Quality and Safety Initiatives in the Department of Surgery at Phoenix Children's Hospital Grand Rounds. I got asked to put this talk together by Dr. Ritchie about 6 months ago, and he asked me to kind of highlight some of the great work that the people in our department are doing to improve quality and safety for our patients. And it has been a real joy. The reality is there's been more projects than we could possibly feature in just an hour, and it's been a lot of learning. And so hopefully you'll find something over the next hour, a project that speaks to you as something you'd like to duplicate or grow on in your own practice here. A few disclosures. I do have some funding not related to the work I'll present today. No other relevant disclosures. My goal to start us off is to talk about how the American College of Surgeons' perspectives on surgical quality and safety, and also to talk about participation in national quality and safety programs here at Phoenix Children's Hospital. After that, I really want to talk about living this work and experiences from the field, and so I have a group of 4 really fantastic surgeons, and they're going to talk about their own experiences with quality and safety initiatives here at Phoenix Children's Hospital. So I always like to start with why focus on quality and safety. And the answer is that delivering safe and high quality care is important to our patients. It is the reason we are here, and it is our guiding principle as surgeons and physicians. We also know we can improve, and for many people, this report from the Institute of Medicine in 1999 about To Err is Human really showcased what a significant opportunity for improvement we have in the health system. There are so many ways where, because of the complexity of what we do, patients don't experience the best possible outcome, or they don't get care the way we want it to be delivered. And so because of that, problems like surgical site infections and near-miss events really become opportunities to learn about how do we make our practice better. And it's really a journey. So I think one thing that the IOM recognized early on in their report is that there are opportunities to get better, but this isn't going to end. We can always improve the quality of the care we deliver, and having that mindset is very important. Taking this perspective, the American College of Surgeons has developed numerous quality and safety programs using a common paradigm. And this will sound familiar, particularly as we talk about the Children's Verification Project in a little bit. But the ACS basically outlines the process as establishing standards, so how you think care should be delivered for your particular disease or your particular problem. Building the infrastructure to support those standards. That means everything from setting up standard operating procedures to hiring or developing staff who can help implement those and providing the training. And then developing databases to measure performance. And as you'll see in a few minutes, there are a tremendous number of databases that have been set up in the last 10 years to help everyone in this hospital do a better job monitoring quality and safety. And then the last step is external peer review verification. And while that is how the American College of Surgeons approaches this, many of us in our own practices have used external peer review through publishing our results or presenting at conferences or sharing with our peers to validate our outcomes. I think it's important to think about how do we embrace the quality journey as individual surgeons. And the answer to that, again, I look to the American College of Surgeons for guidance. It begins with holding ourselves accountable for delivering safe and effective care and saying at an individual basis that this is the care I want my patients to receive, and I'm going to do everything I can to get there. It continues by being transparent and reflective. Transparent in our outcomes so that we can be honest with ourselves about what we really achieve with our surgery and our care and where the opportunities are, and reflective when asking ourselves what can we do better or where can we learn from others. And the third part is really taking a systems approach, making the desired actions easy. And I liken this to if you have a courtyard that everyone cuts right across the middle, you can put a chain link fence up and try to block people from crossing over that courtyard, or you can put a beautiful path so that the easy path is the path that everyone follows, but it also gets them where they want to go. And so on our journey to quality, the way we do that, the way we make the desired actions easy, are by embedding quality improvement in all the activities we do so that those resources are available, focusing on what matters most to our patients and to our outcomes, and then seeing quality as a system characteristic, realizing that an error that happens is not a single provider or a single person's responsibility, but it's a team, and changing how that team works and interacts and the environment in which they live is how we get to a safer and higher quality care. So with that framework, that's not new to many people who are in surgical quality and safety, and it's also a lot of what PCH believes and implements. Here, PCH currently participates in over 45 ongoing programs to monitor quality and safety. A lot of these are quality and safety consortiums and collaboratives. The largest is probably Children's Hospital's Solutions for Patient Safety, or SPS. Those of you who are familiar with Quality Day will recognize SPS projects have won Quality Day as the best project, I think 3 years in a row now. They really set up, national benchmarks. What do we want to work on, and then provide guidance. How do we get there? And then they work with teams locally to help meet those goals. In addition, there are lots of disease-specific registry and outcome studies. Some of the more well-known ones are the STS National Database, which has been probably the leading national database for cardiac outcomes, PC4, CPRN for cerebral palsy are just some examples. So with that sort of big picture, where's PCH on the quality journey? What I'd like to do now is hand off to Dr. Bristol to talk about her work reducing surgical site infections after ventricular shunt surgery.
Good morning. Thank you for the opportunity to participate in this presentation and for the invitation originally to be part of the Surgical Site Infection Committee. So the ventricular shunt part is just a small slice of this committee. As Tom mentioned, this was sort of started by our infection control department and led by our OR leadership to look at bundles or protocols proposed or published by SPS to reduce surgical site infections. And so we started by looking at 3 procedure categories. Mine was ventricular shunt infections, and then we had pacemaker placements and spinal fusions. So really the goal of the committee was to see how good a job are we doing at implementing the recommended bundles, and how does that affect the infections in these areas. I'd also like to recognize Katie Class, also from neurosurgery, who was a vocal and contributing member of this committee. And then from a personal standpoint, this was one of the first committees I was asked to be involved in at PCH. And I can't say I was very excited about it because I'm a little bit of a nihilist when it comes to infection. I feel that we live in a bugs world. We know there are millions more microbes here than there are people. And so I thought, we're good at sterile technique. We use antibiotics appropriately. This is all just going to be a waste of time. Obviously, I wouldn't be here if I'd been right. So, very brief background. Ventricular shunts are one of the most common neurosurgical procedures performed in the U.S. and the world. And unfortunately, a shunt infection is associated with a hospital stay, often of 2 weeks or longer, and that's an ICU stay where the patient has an EVD in their head. So this is a bad complication to get a shunt infection. So it's certainly a good place to start in terms of looking at how do we reduce these infections. So starting in 2012, SSIs were monitored for this SPS bundle that had been put out. And again, this is benchmark data where we have other hospitals to compare to. So this is sort of an early part of the graph, and what you want to look at is the solid red line is sort of our center line, or our kind of average of shunt infection rate, whereas the yellow line below it is the SPS line. And so coming into this, we had a shunt infection rate around 3.5%, which is about what's reported nationally, if that is including adult hospitals as well as children's hospitals. So, I didn't think this was much to work on, but you can see that we are above the center line for the SPS network. Then the dark blue spots are our actual infections month to month. So this is what we were starting with. And in looking at the SPS bundle, I'm actually going to go to this slide first and I'll come back. These are some of the elements of the bundle. One is a preoperative bath. We are amazingly bad at preoperative baths, and I don't know if it's just because that's not on everybody's radar when you have a patient you're prepping for surgery, or everyone thinks of 10 more important things to do, but we continue to be not particularly good at baths. That's a place we can work on. But we added the CHG wipes in the OR, so at least the patient is getting that chlorhexidine wipe down. And the goal is to really reduce the burden on their body. It's not necessarily just at your surgical site. Also, the difference between using clippers and razors. There was one member of our team who could not get the word shaved out of their lexicon when it came to dictating operative notes. And so even if we stopped using clippers 10 years ago, you'd still see shaved in the operative note, and we would get dinged for that in the SPS bundle. Then the whole antibiotic situation, the anesthesiologists are the ones giving the antibiotics, and they would give them sometimes as soon as we got in the room, whereas we might not start surgery for an hour and 15 minutes, depending on the amount of setup. So that required communication between the teams to make sure that those antibiotics were given really at the time of prep, when you'd have the good load in the bloodstream. So this was kind of frustrating to realize that there were these things that seemed pretty easy to do that we were either not doing or not tracking that we were doing them. And so this picture has Laura and Brittany. They are our neurosurgical leads for nurse and tech in our OR. And we were just having a conversation about this frustration and how do we track this? And we came up with this idea to have a physical piece of paper and a book in the room, since we do most of our cases in one room, where we could enter what the parts of that bundle, so what time the antibiotic was given, whether the patient got the bath, etc. And they did a great job on the nursing side of teaching that to the rest of the OR. So it really wasn't very long after Laura produced this book that we would see circulating nurses from other rooms coming to get it if there was a shunt case going in another room. And so very quickly we had all of our shunt cases getting logged on paper with a pen in this book. And the thing that was really amazing is that concurrently with that, the electronic documentation improved as well. So just making people recognize that these were important points that we needed to hit also allowed them to get that into our electronic medical record. So then our SPS compliance came up. And we all became hypervigilant about this, reducing the number of people going in and out of the OR, talking about the chlorhexidine bath, and trying to remind people in pre-op to get that done. And so obviously, as I said, I wouldn't be here if I'd been right. So this is more data over the years. Again, look for that solid red line, which you can see in 2015, shortly after implementing these bundles, we got a drop in our center line, and so we are now below the SPS average infection. You can see it didn't eradicate all shunt infections. There was a year, 2016 was a pretty rough year on our service. We had quite a few, but that didn't bring back up our center line, thankfully. And each of those cases got a root cause analysis, looking to see were there elements of the bundle that we missed, was there any factor that seemed to line up for all of them. So that was very gratifying, and we continue to fine-tune that now. We're now going down to 30 minutes for antibiotic injection, and we're again trying to work on that preoperative bath side. Obviously, one of the things that's challenging in this particular instance is that these are small numbers. There may be some months where we do 15 shunt cases, and so that means in a year we're not going to get a robust number to work with. But if we look over years and years, then it gets a little bit easier to see what things are contributing and not. So where are we going from here? We're going OR-wide in terms of the bundle application. There is still an SSI committee that meets to review SSIs and again work on these other aspects of it. And we continue to monitor our shunt infections as they come up and work towards improvement. So again, thank you for that opportunity.
Morning, everyone. Thank you, Tom, for organizing this again. I think it's a great opportunity to highlight all of our efforts. So our project is titled Acute Appendicitis Direct Admission Pathway. This really was a collaborative team sport approach that began near the end of 2018 and worked through the 12 months of 2019. Would not have been possible without our colleagues in the emergency department. So our problem, or the baseline data, was that we're a large receiving tertiary hospital in the region. We do about 800 appendectomies a year, and about half of them are transferred from another facility in the region. So our existing transfer pathway was sort of a duplicate, redundant pathway where from an outside hospital, they'll actually have a CT confirmed diagnosis approximately 90% of the times. And they do ED to ED triage, and they'll sit there on the first floor of the hospital getting assessed and evaluated by our ED physician staff. And then inevitably there's a surgical consult wait time, and it varies depending on what time of the day it is. And eventually end up in a definitive appendectomy. We found this to be incredibly redundant and clinically inefficient, and there was some embedded economic inefficiency as well along the courses of multiple points of care. So we proposed that what if we were able to directly admit a patient from an outside hospital ED to the 9th floor of the hospital into the surgical service. This seemed like a small change in the pathway, and we didn't realize how much effort it would take to implement this change. Truly was a team sport. I think we instituted a conversation between the one-call operator and the outside hospital ED and our surgical staff. And that ranged anywhere from first-year resident to the fellow on call. And once that's reestablished, we'll go through the radiology reports and as well as the IT platform that would allow image sharing capacity. And then finally, the surgeons had to be on board to accept these patients from an outside hospital to our hospital under our service. So when we first began this pathway back in January, we were hovering around 15 to 20% acceptance rate. And when we regrouped to look at what were the failures or the rejection cause, and we found out that our acceptance criteria was a little too strict. So it wasn't just the size of the appendix. They have to go through, screening bullet points of inflammatory findings and different wordings in the report. So we decided to boldly liberalize that criteria. This took a lot of efforts in our multidisciplinary discussions, and you start to see an improvement in our acceptance rate. And sometime around June or July, we began to discuss monthly report between the ED staff and our surgical staff. And they really brought our acceptance rate up to 80 to 90% near November, December. So the results of our pathway. We didn't realize that they were waiting approximately 520 minutes if they underwent ED to ED traditional transfer pathway. And when we directly accepted them up to the surgical service, we were able to bring that down to 160 minutes. So that's about 6 hours of ED waiting time for the families. We haven't done our patient satisfaction survey yet, but I can only imagine, given the choices, no parents would want to wait 6 more hours in the ED. When we looked at multiple imaging studies as well, interestingly, this is an association, not a causality, but if they undergo existing transfer pathway, the need for multiple imaging studies actually almost doubles. And cost of care was a sort of a finding that we didn't anticipate, but it turns out direct admission pathway was more efficient in terms of obtaining reimbursement. So the way this began was we wanted to pick a high volume disease process in our hospital and attempt to make a small change which could lead to a big impact. And essentially all the stakeholders were interested in this pathway, and I think at the end of the day, all of us found it incredibly meaningful that this actually made an impact on the patient treatment process of care. This would not have been possible without all the surgical staff sitting in the room right now who are willing to accept the phone call conversation in the middle of the night and accept the patients to the 9th floor, basically. And all the surgical staff that were willing to discuss all of our shortcomings along the way in working with our emergency room department.
Justin, could you talk a little bit about what the fears were among surgeons when proposing the direct admit pathway and how you dealt with those fears and concerns?
Yeah, so for the purpose of time, we didn't really get into that, but obviously number one concern was false positive transfers, right? So you have a CT report that says the patient has appendicitis, and they travel 2 to 3 hours, and they get here, and turns out our radiologist would disagree with that finding. So then they would have to turn around and go back. Number two, there is a expectation when the parents and the patients arrive. They've always been told that you're going to have surgery at PCH, and they get here only to hear that they actually don't have appendicitis. So it turns out when we looked at that, it was about 1.9%, which is consistent with our, consistency with our CT report and outside CT report findings. So that took a while, I think, early on. And number two, I think we're also concerned that not only false positive findings, but what about false negative findings, right? So I think all those fears sort of worked itself out over the course of 12 months. And we realized, and we now truly believe in CT findings, even if it's done in outside hospitals.
Can you comment on the impact of the surgical service admitting the patients versus the hospitalists and those two factors with regard to false, who should be the people that are trying to vet the false negatives and positives? Right?
Yeah, so I think early on, the one clinical question we had was, who's going to sort out the ambiguous gray areas, right? They have CT findings, but the clinical picture is really not 100% slam dunk. We realize we are the best people to sort that out. This is our surgical disease pathology. So why have them be processed through non-surgical service from ED to hospitalists, when inevitably nearly 100% of these transfers we got appendectomy, right? So we felt like we could expedite that process. And so decreasing the number of points of care actually decreased number of imaging studies required, which save radiation and multiple cost of care.
Justin, one last question. A lot of times when you begin work like this, it's because you have one or two people in your group who are very supportive, and then you have a lot of people in the group who are, appropriately, concerned that this is not going to work out. Yeah. And sometimes that's discouraging. So just from your own experience, how, when you proposed this, or, you and your team thought about this early on, how many people in your group, or what proportion were like, this is a great idea, just to help those people who also have sort of similar crazy ideas in the future?
Do you want names, Tom?
No, different comments.
So I think when you begin a project like that, you gotta load the boat, right? So I think one way that you could always win is focus on the family and patients, right? So what if this could improve patient satisfaction along the process of care? Number one, right? Number two, you really got to get away from, this is not about us, it's about the group and the hospital, right? So if you focus on decreasing length of stay, decreasing number of hours, from both the care provider side as well as the patient side, you could get away from your individual sort of subjective emotion about this, right? So I think we learned that early on when it was hovering 15-20% for months, right? And it's interesting how everybody's personality really comes out when you have discussions like this. And you have to consistently get away from individual mindset to group mindset. And I think we have that sort of common, philosophy and mission for the hospital and for our patients. And so I think we're able to improve that, as you can see by this graph. Now, I don't know what happened in October, but that requires a deeper dive. But good question. Okay, thank you.
Good morning. Thanks again for allowing me to speak and for organizing this. I'm going to speak a little bit about the ACS Children's Surgery Verification Quality Improvement Program, as well as sort of how that has guided some of our quality work in the hospital, and especially in the Division of Pediatric Surgery. So just a little background on the ACS Children's Surgery Verification Program. This was created because it was recognized that it was important to recognize and identify hospitals that had both the infrastructure and the commitment to quality to provide really optimal surgical care. And I think I'm sort of echoing some of what Dr. Sitzman had said earlier, and that's a big goal of the ACS. This was modeled after the trauma program as well. So we are currently a level 1 children's surgery program, and there's level 1, 2, and 3. Again, this is not meant to identify differences in quality, only differences in resources. So if you look at the triangle there on the slide, there's several large components. The first is the infrastructure, and that's both physical infrastructure as well as personnel infrastructure, and having the number of people and the infrastructure in the hospital and outside the hospital to be able to provide optimal care. The second is we do participate in the Pediatric National Surgery Quality Improvement Program, and that is a national program which provides risk-adjusted outcomes data. And we have been participating for 4 years in that. That's when this whole journey began. That was a prerequisite to being able to apply for our verification process. And then I think for the purposes of this talk, I think the most important part of this is the PIPS meeting, or the PIPS process, really, which is sort of a performance improvement and patient safety process culminating in a meeting. And that's really done a lot, I think, to help us with quality care. And obviously, again, to echo what Dr. Sitzman said, our goal is, transparent, quality patient care. Whoops. And, why do this? So to echo what Ruth was saying, we all think we do a pretty good job with our surgical patients. We give them antibiotics, we review our complications, but we often exist in a silo, and so it isn't just about us. There are so many things that happen outside of our silo that contribute to our outcomes. And so the idea is to break down these barriers and to really provide a comprehensive surgical care of the patient, starting pre-hospital and really going post-discharge. And that involves so much more than the individual surgical services. And so we really needed to break down those barriers. And I think the PIPS process is kind of what I'm going to talk about, and that's the performance improvement patient safety. And that is a way of self-auditing and reviewing a list of, and I don't use the word complications because that's kind of a trigger word for us as surgeons, events or occurrences that occur in the perioperative process. And it's a really a 4-step process. So we identify these events and occurrences, and they're reviewed at multiple levels, starting with our program manager, moving on to me and our program manager, and then we really rely a lot on the PCRs for the individual services, and we like them to review those processes. And what we're trying to identify is not judgments on individual providers' performance necessarily, but opportunities to improve care from a systemic process. When there are such cases that we have identified, those go on to our PIPS committee. And ideally, what we would like to do is break down these silos, and so that we can have a standardized process of caring for surgical patients. So our PIPS committee, which meets every other month, is a true multidisciplinary committee. It has representation from all of the surgical subspecialties and, in fact, other specialties that are procedural that are not surgical, as in GI and interventional radiology. We have NICU, PICU, CVICU. We have perioperative staff. We have quality representation. We have nursing representation. And it's really been helpful to see that we think we're doing a really good job, or we don't know how this could have been done better. And someone from another service will go, well, when we're in the OR, we do this. And you go, oh, what a great idea. So this has been a really helpful process for us. So in terms of challenges and failures, so this list that the ACS requires us to review of events or occurrences is actually pretty comprehensive, and we were having a very hard time capturing all that data initially. We now have a dashboard that is able to capture that data from multiple different sources. And I think that's really helped out. The other was just trying to get people to bring their cases, try to coordinate the channels so that people were referring the cases from their PCRs. and really getting buy-in from all the surgical services and the other services who don't necessarily perform surgeries, and we're asking them to participate in this process. And, you know, in general, people feel like when you come to them and you say, we want you to talk about your events or occurrences, they feel that it's a judgment issue. And in fact, once people realize we're really all getting together to improve systemic patient care across the board, I think we've gotten good buy-in from this process. To move on to some more concrete examples of what our quality work has been able to do, and this has been presented at a national quality meeting, the last American College of Surgeons Quality and Safety meeting from last July. So we all do G-tubes as general surgeons, and what we realized, and this parallels the process of when we started entering data into NSQIP, that we were all across the board in our postoperative G-tube care, and that each surgeon had a different way of doing it. And this was really driven by our APPs, and our lead APP at the time, who's no longer with us, but she was able to get buy-in from 12 or 13 surgeons to say, yeah, okay, we'll do it, we'll all do it this way. I'm okay with that, and we'll see how it turns out. And essentially the protocol involved fairly early postoperative feeding, a standard objective discharge criteria, and specific feeding regimens. So we were able to reduce the length of stay from 3.7 to 2 days and reduce hospital cost as well. And although we didn't specifically look at this, there's been no evidence that we've had increased complications or increased readmissions after this. Another sort of intra-hospital thing that was discussed and we worked on in our PIPS process, we presented a case of a retained object and actually identified a number of factors that had nothing to do with careless surgeons or, you know, somebody not paying attention. And so we really did a deep dive and brought this back to the PIPS committee and just found out that, once again, as is often the case, poor communication, poor compliance and collaboration. And so we updated our procedures for sponge counts, which you can see before, being really rigorous about getting initial counts, having to announce when there is a sponge in the cavity, and that is marked, so we know if that mark is still on the board, we haven't accounted for the sponge. And then particularly in the CVOR, they get x-rays instead of trying to decide whether you have the right count or not. It's just standard to get an x-ray, if I'm correct, Dr. Velez? Yes. So, and now we have new sponge bags that are easier to count. So these are ways that you don't think of as a surgeon always when you're in your silo. These are things that come from outside and they can help.
Dee Dee, it's really fantastic work, and thank you so much for leading this effort. It's just, I think, a pleasure for all the surgeons here to work at an ACS-verified children's center. One question I had for you about the G-tube work.
Yeah.
My experience has been that the APPs are actually hungry for this sort of standardization, and they want it. And in plastic surgery, we've been successful, not just in having them support, but having them lead a lot of the standardization efforts. What's been your experience in general surgery?
Specifically for this G-tube work, that was pretty much entirely APP-led. We had, surgeon support and surgeon champions for the project, but this came from them because I think it was extremely frustrating for them to go, well, this is Dr. Rowe's G-tube, and she likes to start feeds, 5.5 hours after surgery, and they can't go home until post-op day 2, and so they said, guys, can we all just do it this way? And they looked and found a protocol that made sense. And we're, I think, lucky in that we all just said, okay. I think when you talk about how do you get buy-in from a large group of people, this was relatively easy. I think probably a lot more easy than poor Justin's job in trying to get us all to agree to admit APPs directly to our service in the middle of the night. But our APPs often bring up things that they think would be great for us to do. And so I would love to see that across the board because, this is a kind of care that I think really made a difference for our service.
Dee Dee, thanks for that.
Yeah.
Can you just give us your view of You commented a little bit about buy-in, but not so much even buy-in or just perception, individual perception and divisional perception with regard to PCRs in relation to PIPs. You made the comment that, we don't want it to be, accusatory or blaming. And have you seen the shift in that?
Absolutely. So with regards to the PIPS process and with the NISQIP data, because the NISQIP data comes out as a semi-annual report every 6 months, and it ranks you de-identified against other hospitals. And really, it did take some time to say, we're not here to judge you. We're not giving you a bad mark on your report card. We're trying to figure out what's going on here. And in some cases, we found out that our data entry was incorrect. In some cases, we did identify problems that could be solved that didn't have to do with individual surgeons or individual groups of surgeons. And I think historically, our PCRs as surgeons and M&Ms have been a little bit more accusatory. And so I think people really, I have seen a change. And people now will volunteer. They say, hey, I've got this case. We should talk about it at PIPS. And I will say in the beginning, and I will give credit to Janelle for being a little bit, insistent that we needed people to bring these cases, and we would tell them you have to present, and much more now people are actually volunteering to present.
Dee Dee, one other notice from being in the PIPS, one of the things I find is having nursing staff, OR staff, intensivists there. It's the rare opportunity to have everyone involved in the care. Can you comment on that, sort of how you've found it helpful to bring cases to PIPS to get that other input?
That's been extremely helpful, because when we identify a problem and we say, well, we don't know how to figure out how to do this sponge thing, we have, Barb Pankratz, who's the head of perioperative services. She's got a plan in place, that right now. So write it down, and then if it needs to go to nursing education, or we have nursing representation as well. And if there's an issue, like say we had identified the issue that had already been identified in terms of pre-op bathing, that can go down that way. And we have loop closure too. So if we identify a system problem or we identify a plan, the idea is that comes back at another PIPS meeting where we have follow-up. And that's a really important part of this process, is the loop closure. We can have great ideas all day long, but if they're not implemented, it doesn't help at all.
All right, good morning. Thank you for the brave souls who showed up and the ones that are stay awake while online. Tom, thanks for the invite. Actually, before I start, I want to give a shout out to Dee Dee and the team for the PIPS. As a frequent flyer, I think we hold a special spot for pretty much every meeting, but I can attest that we have received the benefit of closing the loop, and as I'll share later, we're going to have a shift in the Heart Center how we look at things, and it's actually pretty similar to what is happening at PIPS. Let me see if I can. All right, wrong button. There we go. So in the Heart Center, our approach is to have a system-wide perspective to quality, and we do have an early experience using data to improve outcomes or find or figure out opportunities for improvement. And this has been through collaboration while using databases and participating in collaborative efforts. And you see NPCQIC, PC4, and the Society of Thoracic Surgeons. I'll make a few comments coming up. It is really an idea where we have to shift our mentality, our culture, to understand that quality belongs to the team, not just the surgeon or the particular practitioner. So I won't dwell too much on the bundle, as Ruth already explained, and it was very similar to the same process for all specialties, but I'll take you to what I lived in terms of wound infections when I first joined. So I joined Phoenix Children's in 2012, and as soon as I walked through the door, I had a couple surprises. Number one, I thought there were just going to be 2 surgeons. Suddenly there were 4. What was happening to those surgeons, eventually, you guys know the story. But what was interesting is my experience, because I trained in many places and I trained in places where they had multiple surgeons, is that When you come to a place, you find out what works and you stick to it, you imitate, and then later you can implement your changes and adjust to some of your liking. So when I was asked, how do you want to prep and drape your patients, I said, well, what do you guys do? Well, A, B, and C. You pick one. So that right off the bat became problematic. And then I started seeing that we did have a higher than expected or higher than I expected rate of superficial wound infections. And it's hard to see there, but that started January 2012, and the apparent issue goes all the way through 14. Mind you, all throughout that time, we have been working on implementing this. You see a drop later, as I'll show you in the graph, in terms of the wound infections, superficial wound infections, but the reality is that there were many changes more than just the bundle happening in the background. I keep turning it off, I apologize. So we established the bundle at the same timing that Ruth explained, but I'll share a couple of things that happened in the background. What I learned was that everybody had a different dressing to put on the patient, number one. Number two, I don't know if you all remember the history of the Heart Center. It was a marriage between the McCoys and the Smiths, right? Suddenly St. Joe's and Phoenix Children's joined, and if you brought a patient up with dressing X that wasn't the St. Joe standard or was not the PCH standard, you already had a little bit of a conflict. The other thing that I found out, I've always been very structured with the timeout in the administration of antibiotics. So I did find out that, not the other three teammates were perhaps not as structured. That doesn't mean they didn't want preoperative antibiotics, they just were not as structured as making sure that it was delivered in the timing that they intended to. Documentation of that delivery of antibiotics was all over the place. Documentation of the use of vancomycin paste was or wasn't being achieved. We also addressed or found out that nutrition was a big deal. Some patients were receiving nutrition, appropriately, some weren't. And if you think about it, the two things that are needed for healing and prevention of wound infections are oxygen delivery and nutrition. So if you don't nourish a patient who's already hypoxemic, boom, here you have it. It's our rate of wound infections. So cleaning equipment, believe it or not, as simple as I'm waiting there for my patient to be transported, and I see the EKG leads go across the chest before the dressing was on. So whoa. We changed that, and that didn't happen, and I grabbed a wipe, and I wiped the cables, and you don't want to see what I found. It was pretty nasty, and obviously explains what the issue was. So suddenly awareness, and also a reduction in the end of the number of surgeons. And for the number of years, or 6 years or so, it became just the two of us, which is a lot simpler to implement things when there's just two people. And my former partner was kind enough to say, whatever you say, we'll do. And it really worked out. And the OR team, I got to give it to them. They were very flexible. They were open, as was the CVICU team. Now, here's the big difference, right? As soon as we implemented those changes, and they all did not come at the same time, you see that our center line pretty much dropped to zero for many months, and we just had the occasional blip here and there. Impossible, like I said, to achieve a 0% of wound infection. We have patients that are hypoxemic, that have low oxygen saturations, and have nutritional issues that will never change. Now, the learning through the collaborative, so just a couple of comments here. We have always participated in the SDS database. The inception of the database dates back to 1989. The congenital arm of it, I believe, sort of started making noise around 2006, 2005, and eventually became a very good tool to see how you were performing. The one thing that it doesn't do great is the collaboration aspect. Actually, it doesn't do it at all. It just tells you a number and how you relate to your observed versus expected performance, which is very good. There are some issues with the risk adjustment, but it's what we have. It's a great tool. The problem, I'll make a comment here, the problem is that slowly the specialty has turned into a little bit of a circular firing squad. And unfortunately, even if you are one of the last people standing now, there's people outside the circle who take a shot. So we need to do much better than just identify and report these numbers for matters of ranking and status. And I think that's where the PC4 and the NPC-QIC are very strong. These are databases that collaborate, that you're allowed to reach out to your colleagues and say, hey man, you don't have readmission rates that like I do. What do you do different? It also allows you to establish projects and investigative, projects to find out more on how to achieve these goals. So I think the shift to a collaborative where we actually share same pieces of data is the way to go for the future. Now, I mentioned that quality belongs to the team, and as I look at what we all do in M&Ms, and again, I've been very fortunate to be in many institutions. I've seen it how it's done in different places. Now, to go to many institutions, also you have to interview in many programs. So I've also been exposed to not just the programs that I've worked in, but sort of seeing the M&Ms or the meetings in different programs. Specifically Toronto, that was my first contact with what I'm going to explain here in a second. So currently, how do we do our M&Ms? We have an event, we have a patient that comes in for a planned procedure, and we look at an outcome. And we say, okay, surgery X had outcome Y. Why was that? And we try to figure it out. 9 times out of 10, it sort of has a potential flavor to be punitive or perhaps assigned to the performance of, let's just say, the practitioner, the surgeon, the gastroenterologist, whoever performed the procedure. But I think we should change that. And I think it can be dramatic, not just for the heart center, but even adopted across the board for the other specialties. We should aim to look at the whole journey for the patient that underwent the procedure, and our goal is to do it for every patient that has a surgical procedure in our program. So we put in place a process where each journey is scrutinized for threats and errors, and that comes from a NASA model of threats and errors. Every flight gets analyzed, and every turbulent moment or every deviation from the flight plan is analyzed as to why, when, is there a possibility to change, what was the cause and effect. So the information for every patient can be depicted as a flight path, and then deviations from that get analyzed. It's actually a process where we have to change the thought of or create a divorce between outcomes and performance, because we all have had bad performances that turned out to have a good outcome. But we also have had great performances, and dang, that's very painful when we don't have a good outcome. I'll give you 2 examples. I'll be brief. You do a Norwood procedure, one of our most complex procedures. It's easy to understand that if you don't do your connection between the tiny aorta and you don't provide good systemic flow, uninterrupted, good mixing, good pulmonary blood flow, you can have an issue. A couple of pump runs, sort of fumble in the operating room, you sort of can predict, or you wouldn't be surprised to have a good outcome. But let's just say you have a long pumper and you redo a couple of things, you send the patient to the ICU, but flies and out of there in 2 weeks. You escape free. Do you want to repeat that? Is that the way you want to perform? Not really. The opposite, it's you have a perfect operation, close to 2-hour pump run, close the chest in the operating room, great oxygenation, great saturation, send upstairs. For whatever reason, not for whatever reason, you need to diurese the patient. We don't follow the potassium. We have a dysrhythmia. We end up on ECMO. We receive the appropriate blood transfusions and products for ECMO. Patient weans off, goes home. Yeah, good outcome. I mean, we escaped that one. Yet, over the next year, the patient's heart function decreases and needs a transplant, gets the transplant, has rejection in the first year. That's a quality marker for the transplant team. Let's just say the patient rejects so severely and succumbs to the transplant. Is the problem the management of the anti-rejection meds? Is the problem the operation at the beginning? No, I would venture to say the problem was the monitoring of the potassium that led to ECMO, that led to blood transfusions, that led to antibodies, eventually, and eventual rejection. So again, 2 examples of both ends of the spectrum. So we need to finally, or I propose that we divorce performance from outcome. And here's the depiction. So every patient lives at a standard or baseline risk, right? In congenital heart disease, you're never zero. So you get admitted to the hospital, as you see that purple line is not down to zero. You go to sleep and you have your operation, your risk increases dramatically. So you spend your time in the OR, the risk should start decreasing over time. You leave the operating room, you're still intubated, you're still at a higher risk than when you were from home, but over time you get extubated, you have pressors and medications weaned, eventually you make it out to the acute care unit for cardiology, and eventually home, you're discharged. So the idea here is to have boxes at the bottom of the timeline, as you see, where CT surgery or the surgeons would give a numeric feedback to the performance, better than expected, as expected, or below the expectation. They all pretty much should be as expected, because an operation that is better than expected should be one that you didn't have to do what you wanted to do and you just went great, or you just passed your hand over, the patient got better. So usually should be better than as expected. There's anesthesia feedback, and there's ICU feedback, also for the stand-up floor for the cardiology group. So here's an example of a specific patient. So at the top, you'll see the name, the medical record number, and some identifiers, the age of the patient. I don't know if you can see it in your screens at home, but there's a attending for the CVICU. There's the cardiologist, or the surgeon, the attending in ICU, the cardiologist on the floor, and the primary cardiologist, and then whether or not we follow a pathway. And then there's the admission diagnosis. Next to it, to its right, there's a surgical repair, and I think this is very important. I'll use the same example for this, because this patient had an enlargement of a VSD. The risk of this patient to have heart block is very different than a regular VSD closure. So in the discussion, we do need to be aware, because when we report to STS, what do we report? Just heart block. And we may actually make the notation, but it's not until we do the deep dive that we find out that the rate is different, right? I think also I would add a third column there in the gray area that includes the risk factors. Was this patient intubated before coming in? Was this patient feeding? Was this patient underweight? Did the patient have intracerebral bleeding prior to, etc.? So if you go down to the depiction of the flight, you have the team performance, so that you have time in the horizontal axis. You have the team performance for each members of the team, ICU, surgery, and actually I don't think they have the anesthesiologist, and then green, yellow as well for performance. We depict the details of the events as they have occurred. You see the patient had a chest tube removed, developed a small small pneumothorax. On the floor, the pneumothorax was resolved, et cetera, et cetera. So it actually really identifies every single. It's labor intensive, obviously. Every patient has to be followed for the whole journey, but you don't go by go and collect 200 without being identified. So what are the benefits here? Well, collective memory is reinforced. We identify the opportunities for improvement. The process is clarified. Communication gets better. It builds team effort and closes the loop. But also enhances the analysis of the real-time data. I mean, it's a lot more valuable. There's recognition from the deviation of the flight path. We can expand the feedback and the discussions. It increases understanding of the patient and even the family perspective. Care coordination is also a benefit. And we can capitalize, I should say, on successes and or failures too, to better understand also even positive deviations. Now, I have to say, there's also improvement in accountability. As I mentioned, we would have, let's just say, a primary intensivist who can say, hey, chief, you forgot to check the potassium. The kid I admitted last week. What's going on? So you raise the bar to all the team members, and again, forgive me, the ICU team, I'm just using that as an example, but we all hold each other accountable as now we all have skin in the game. Now, this cannot be done without partnership. And I have to mention, I had inverted the order. We recruited Josh Cook in 2018, and I don't envy his position because he has to arbitrate the change in culture to allow this great communication, or this much improved communication between members of the team, surgeons, cardiologists, and intensivists. So he has a big interest in quality, so it's very easy to collaborate with Josh, and I think we're headed in the right direction. Also on the surgical side, you do need a champion for it, and our newest recruitment from last year was Dr. Russell Bryant. He will take on the role of surgical lead for the Heart Center Quality Initiatives. Fortunately, without knowing, I later learned my second contact with the flight path or flight plan approach was then in Cincinnati when I went for some VAD training many years ago, and I saw how they started doing it. I revisited years later, now with it completely established, and the transformation is dramatic. So he has lived through that, and I think it'll be beneficial to have him plugged in to help us do this. Along with this, stay tuned, because as one of our first visiting professors for the Heart Center lecture series, we're going to invite Dr. David Cooper, who leads the ICU, cardiac ICU there in Cincinnati, and he was instrumental in implementing this pathway. So hopefully he'll come visit, hang out with us for a couple of days, and share his experiences of it. And I got to tell you, I think we have enough data to write our story and eventually publish it and share it with the community. So with that, I'll just take some questions.
Dan, thanks so much for a great talk. One question I had, there's a theme about bringing the whole surgical care team to the table. When you're reviewing these flight plan, who's in the room? Like, who are all the people and specialties that are part of it? How broad does that circle go?
Right. So, Tom, this actually, not just for the flight plan, this actually started, was one of the things I started changing. I held the title for quality person for a little bit as well when I first joined. And believe it or not, we didn't even have M&Ms back then. So it took a lot of beating to, number one, have the meetings, prepare slides, not just come in with what you remembered off the top of your head, and being comfortable inviting pretty much every member of the team. And that we have expanded and actually kept that all the way through today, and will hopefully continue. So our staff, perfusionists, echo techs, nurses, physicians, students, residents, fellows. So it is really open to everybody. And I can tell you the surgical team also lives through basically the golden rule that we all are human, and if anybody sees anything going on that is outside the usual expectations, they should speak up. Same is carried down to those meetings, so everybody should be able to feel free to make a comment or point something out.
Great. Well, it's wonderful to see the whole team involved there. I just want to say a thank you to all our speakers today and everyone who logged in online to watch us. So thank you very much.
Thank you.